word here is acceptance. A lot of people are in denial. They do not accept. They don't want to know that this is happening to them.
As a person, as an individual, we've not learned to let go of control. Our body is the most sacred space that I have. And now I have 5 people poking it. So now what happens when I was eating right, I was very fit, I'm young, and I'm diagnosed with a cancer which is unexplained. Where is the solution to this problem? Who do I blame? You might experience anger. You might experience frustration, which is causing an impact on your relationships. You don't know how to manage the emotion because you don't know what triggers you.
This is Zen-Brain, where we try and have conversations that we normally don't have. Personal conversations, conversations with experts or research done in the area of cognitive neuroscience, conversations about how stress affects our brain, how grief affects us, numbs us almost, and its impact on our mental, emotional, and physical health, or trauma for that matter. Even how serious illnesses like cancer affects entire families. We also have conversations around relationship dynamics and how to become more self-aware. So do check out zenbrain.com, and on our YouTube channel, you'll find over 100 videos. And now you can also listen to our podcast on Spotify. And if you have a story to share, get in touch with us. We are active across our social media platforms on LinkedIn, whether it's Facebook, Instagram, and Twitter. And today we are talking about cancer and mental health. And this conversation is tough. But if you know of anyone who could benefit from it, do forward this to them. I remember a couple of years ago, our family didn't know what to do, how to react when my brother was diagnosed with stage 4 cancer. And we were told that the prognosis was poor. And I remember at the time looking online for something, anything that could help me make sense of what was happening, how to help others around me, my parents, for instance, but I barely found anything in the Indian context. And that's why these conversations are important. And yes, I'm also from a family that didn't think mental health was even an option. Even personally, I'm surrounded today by people who don't believe in it. That's okay. These conversations are not to try and convince anyone of anything. It's to merely bring out points of views. So yes, today's conversation is heavy, but we need to have them. So here is cancer warrior Radhika Manaktala and onco-psychologist Hiba Siddiqui. Now, when someone is diagnosed with cancer, the first response is shock and extreme fear. And I'm not just talking about the patient, but loved ones, including family and close friends. And usually the standard response is loads of advice or gyan, like you must be strong, be positive, or there's no time for fear. I too am guilty of saying these things, but it's easier said than done, isn't it? When you yourself face it, all this advice sounds ridiculous. That's why today we have people who are living these contradictions daily and do know a thing or two about mental health and mental strength, especially when dealing with cancer. Now, Radhika Manaktala was diagnosed with stage 1 breast cancer. This was 2014, isn't that right, Radhika?
That's right, August 2014, yes.
And after what she went through, she now runs a cancer support group at a hospital in New Delhi. We also have an onco-psychologist, Hiba Siddiqui, who helps cancer patients and caregivers navigate what would otherwise be a very, very scary and confusing road. So thank you both for joining me on Zen-Brain. So Radhika, let's begin with you. Days leading to your diagnosis and the day you were told it is cancer. Take us through that.
Right. So as you said, Shruti, most people, their initial reaction, almost their reflex reaction is shock and fear. And I was no different. Shock because we always think this is something that's going to happen to someone else. It's never going to happen to me. And fear is largely the fear of the unknown. We don't think about cancer. We don't even learn anything about it because, it's until it's staring you in the face. It's got nothing to do with us. And then you are given this diagnosis of cancer. Mm-hmm. So first thing is shock, followed by fear. And also, whatever little information we have, it is gleaned from films, it is gleaned from the media, and both these mediums, they are not always very accurate. And they also tend to dramatize things. So that is where I was coming from. And but I had very old and unwell parents. I had old and unwell in-laws, and my son was just finishing his education in the UK. He was alone there and was starting a career. So I had this very strong desire to protect them, this need that I needed to protect them. And the only way I could do that was by not showing them how shattered or how devastated or how scared I was. But, you know, it's not easy to appear calm when you're churning inside. You don't fool anyone. So my husband and I talked about it. And I said, what are we scared of? And the questions were, am I going to die? Is there a treatment? Will I be able to take the treatment? Am I going to be incapacitated? How does this go? How does this work from here? And the answer to all these questions was, I don't know. And that's when we realized that the fear is coming from a lack of knowledge. It's just ignorance. So we decided, let's learn something about this. Now, I'm lucky because I have several doctors in the family, including oncologists. And the oncologists put us on to other oncologists who then became my treating doctors. So we went to them with this long list of questions. And once the doctors realized that here was somebody who could understand what they were saying, who could process the information they were giving us. You know, they answered all our questions at length. They told us where to get more information, where not to get information. Don't go on to Dr. Google. And they were kind of guiding us. So from the time that I was diagnosed to the time of my surgery, which was the first step in my treatment, there was a gap of about 15 days. And in that 15 days, I tried to learn as much as I could. So when I went in for this surgery, I knew not by gut feeling, but by knowledge that at least in the short term, you know, in the foreseeable future, I would be okay. And just knowing that kind of lessened the fear, started to build the resilience. So that is how I started treatment. What happened during treatment is a different story, because I was met with a set of challenges I never thought I would have to face.
Did you seek any help with a psychologist, with a mental health specialist?
Right in the beginning, no, because as I told you that I didn't even feel the need. I had I had information which was kind of helping me to come to terms with my diagnosis and also making me see that I'm not too badly off, right? So at that point, no. But later on, yes. And sadly, we had nobody at that time. Hiba was not part of our team at that time. And we had nobody.
That's why an onco-psychologist is important. What are the first few steps that you suggest to patients when they come to you?
See, Shruti, the thing is that the first steps for me, and even for most mental health professional, is making the person who's coming to you or who's visiting you, including families, including patients, or the individual themselves, to make them feel comfortable. You're already in a very, very jarring environment. You're very vulnerable. You're very emotionally fragile in majority of the cases. Even like Radhika was saying, that somebody like her who's coming with a plethora of information can still feel fragile or internally just very shaken up, not knowing what's going to happen. So that uncertainty is pretty large, right? So when they're coming to you, you're somebody who's not a necessity. That mentally, quote unquote, I'm strong, so I'll deal with it. So I'm not going to someone who's telling me how to deal with it, because let's cut to the chase, let's get the treatment started, because that's the real thing. So between that and me, I'm an option sometimes, initially at least, right? Now so when they come to me, sometimes they come on their own because they realize, and now with, I think COVID and post-pandemic awareness of what anxiety is, what depressiveness is, it's also become a common theme. With oncology, sometimes people are more comfortable coming in. And so the questions that come in that, will I be okay? Will I die? You must have met so many patients. Do they even make it? Or the doctor's just telling me to, get the treatment started. So a lot of times they come in with those kind of questions. My first aim or goal with most of the people is to make that space comfortable. I don't dive into any interventions in my 1 or 2 sessions until they trust that space. they consider it emotionally safe to be able to express those concerns, that shock, that trauma, even the worries at a more familiar level. So I think that's my very first aim, because if they're not comfortable with me, it's a long treatment, right? A couple of months in, you're with me, with us rather. So if they're not comfortable in the first go, it'll be very difficult for them to sort of reopen that space. Sometimes people just come and meet me, and then they meet me a few months after that. Now I'm ready to talk. But because the first day or the first session was comfortable enough for them to say, okay, now I can return, I'm now ready to have a conversation. So I think that's what the initial conversations do. So that's usually what I sort of bring to the table, at least I attempt to.
Radhika, let's talk about the challenges that you spoke about.
Yes, I'd just like to begin here with what Hiba said. It takes time for the person to be comfortable talking about their challenges. 3 or 4 weeks into my treatment, I lost my mother-in-law. And my mother, shortly thereafter, fell very ill, and she went into hospital. She was there for 3 months, and she never came back out. We lost her. And in the middle of all this, my husband had a horrible accident. He had to have surgery himself. He was a convalescent for about 6 weeks. So all this, and I was, maybe 1/3 of the way into my treatment. I was more of a caregiver, less of a patient. I had nobody to turn to. And as I said, that is the time where I could have really helped by talking to a professional, but we had nobody. So fortunately for me, my doctor was a gem of a person. And by that time, I had known him for a couple of months. As Hiba said, you have to be comfortable with that person to be able to unburden yourself.
Mm-hmm.
And he had the patience to sit with me and listen to me, unburdening myself, the tears that were flowing. And I felt comfortable with him because I had known him for a while now. But I also felt that, when you don't have a choice, you tap your inner strength. And all of us have that inner strength. It's just a question of having the willpower to, tap it and bring it to the front. And that is when the resilience that had begun to build in the initial stages of the treatment started to strengthen, mainly because I had no choice.
Just let me talk about inner strength and resilience that you talk about, right? Is it more about being able to process what you are going through, come to terms with it, accept it, and, somehow find that courage, which we all have, and muster it up and move on?
The key word here is acceptance. A lot of people are in denial. They do not accept. They don't want to know that this is happening to them. It's always that, why is this happening? That why me syndrome is very prevalent. So they don't want to rationally think about, all right, this has happened, but these are my options available. And if I do this, I will be all right. They just don't go down that path. Somehow we are a very emotional people, and we think more with our hearts than our heads. But yes, as you said, once you're able to accept it, then you're able to deal with it.
Hiba, what's been your experience?
I think one aspect is what Radhika spoke about, and that's a lot of people come with that. The other interesting aspect, and a directly opposite thing to what she was saying, was that people are there with acceptance. What happens to the aftermath of that? So now I've accepted, I know what to do. I have to have line 1, line 2, line 3 of treatment, what to do next. So the question then comes in the emotions that come afterwards. The other part is that a lot of times people find it difficult to accept, or the whole why me that she was talking about is because I have not learned as a person, as an individual, we've not learned to let go of control. Our body is the most sacred space that I have. And now I have 5 people poking it. I have 5 people, doing intense treatments on it. And it's really raw, right? Like literally and metaphorically. And so I'm feeling very, very barren, and I'm feeling very uncomfortable being touched or seen. So the denial also is because we're all taught as people, and I guess maybe in Asian Indian communities as well, that we're taught to find a problem, the solution to a problem. So now what happens when I was eating right, I was very fit, I'm young and I'm diagnosed with a cancer which is unexplained. Where is the solution to this problem? Who do I blame? So you start questioning these very existential questions, which are very difficult questions and no easy answer, sometimes no answer at all. You might experience anger. You might experience frustration, which is causing an impact on your relationships. So the treatment is a sideline thing. Now we're talking about the impact that's happening on the carers as well. You don't know how to manage the emotion because you don't know what triggers you. So then it becomes a more team game where people are just doing self goals and not realizing that you're actually having to goal at the same thing. You're all in it together. So that's where the emotions have to be contained. And that's the safe zone that I was talking about initially.
No, it's interesting that you brought up this whole concept of helplessness, letting go of control. I had never thought of that. And it's literally everyone in the family and the patient themselves need to let go of a lot of control. Emotions flying high, family dynamics changing at that time. Right? You talk about anger, you talk about all, the emotions coming to the fore. So the family is left to handle not just the disease, the cancer itself, but also the peripheral things that we don't seem to give much importance to, but that also impacts dynamics at that time, right?
Absolutely. And the impact, it's interesting because, when we're talking about what are we letting go? Are we letting go of what I'm supposed to do today? Am I letting go of the next 3 months of my life, next 8 months of my life? Am I letting go of physical independence that I value so deeply, but I kind of took for granted until now? And you're also in a lot of spaces where sometimes people are very guilty doing something that has led me. For example, I delayed treatment, or I, ignored my symptoms. I'm educated. So what happens there, right? A lot of shame that you're attaching to yourself. And it's all very helpless because the time has passed. You're there, you've given a diagnosis, you're given a treatment. Now it's your choice, and it's a very avoidance kind of a conflict. You ignore, you're the one dealing with the aftermath of it or the repercussions of not going ahead with treatment. You go ahead with treatment, you're still bearing the side effects. Right? And also the tag, the label of being a patient diagnosed with cancer is very stigmatizing to the who's who of the society.
I don't know why, but we have this stigma about talking about the disease, talking about illness, talking about the treatment, because they are so concerned with what others might think. We have the who's who doesn't want to talk about it because that might affect their career, their popularity, the whatever. We have ordinary people not wanting to talk about it because what will the neighbors think? There have been women in the support program who say they don't even go out into the balcony because the neighbor might see them without hair or with a headscarf, and then they'll ask questions, and then they'll have to tell them. And of course, we can't tell them because what will they think of us? So this stigma around the disease is something we really need to work on to get over, to be able to come out and talk. And if the who's who won't talk, I'm not sure who will.
That's shocking to hear. So Hiba, how do you respond to somebody who feels stigmatized? How do you handle it? What is the advice that you can give them?
So sometimes when this happens, right, I have to check in what do they want. And, Shruti, when we talk about patients, being the center, you're carrying out this conversation to look at how mental health for somebody in cancer, people experiencing it or affected, not just the person, but other people. We need to realize that we need to work with the patient as a team. If the patient is at the center, we have to revolve everything around them and make them have the agency and the control that they actually feel they don't have. Because if the patient, sometimes they're not okay talking to me. That's also happened many times, right? So I've been given a ward referral and I go and said, you know what, please call the surgeon. I don't want to talk to you. I prefer a surgeon. So they prefer being taken to the OT than to talk to a mental health professional. Now, how I flipped it was I used that as a rapport building. I was like, just look at me. I'm tiny. Do you even feel scared of me? Like literally, you're willing to call the chair to operate on you, but just speak to me. It's better. I'm telling you. So we would have some, sometimes we would flip it into a joke. I would like make that as a rapport space, but obviously not with everybody. Sometimes they feel offended. Why did the doctor send you? The moment I introduce myself. And I don't like hiding, I don't like saying, oh, I'm Hiba, and then muffle who I am. And, it just sometimes some of the doctors used to tell me, just don't mention, not presently, long back in the early part of my career, don't say you're a psychologist, the patient will never talk to you. And I would comply because I was very junior, I was very young, and now I refuse to. I said, you know what, this is who I am. And so when I make it about like, I joke with the doctors, if my headquarters are not okay, your body's not going to be okay. So take it or leave it. And sometimes humor helps, right? Sometimes you lighten the intensity that oncology brings with it. And I was talking to you, when we were having our informal conversation a few days ago, I was telling you that this is how, as a team, we bring about, we laugh and we joke and we think it's necessary for us. But coming back to your question, if someone is not willing to talk to me, I tell the families, please don't force them. They're not ready. Many times what's happened that sometimes people have said, I don't want to talk to her, but they saw me talk to her. We have an open daycare in one of our units here. So they saw me talk to somebody else and they probably overheard from that little, and they said, yeah, but now I can talk to her. So they did like a secondary therapy session through another patient. And they said, okay, this is not as jarring or scary. And when they're willing to talk, they come with that control. They come with that patient centricity of I'm taking things in my control. So advice I don't usually like to give, but I often tell them that, we're working as a team. We're here. You want to ask questions 100 times, we will answer 101 times. It's your right. And if we get irritated, then we call out each other on it. That listen, the person will ask. You're seeing 20 patients a day. The person is for the first person diagnosed and then family. So what I usually tell them that, do you want to not wear a scarf? Yeah, it's hot, it's humid, my scalp gets itchy, I don't want to. I said, what will happen is people look. Nowadays people are shaving their heads. I said, do you look at them? I said, no. Earlier pre-pandemic, when you wear a mask, people would know you're a patient of cancer because most likely, right? Unless you have some immunocompromised other concerns. Post-pandemic, every single person was in a mask. And they said, now I go to the mall, now I window shop, nobody knows because we're all the same. So this is what standardization does when we normalize conversation. We're all the same, right? That you and I are not different. I'm not a patient and you're not healthy or you're not normal in their words. So when we destigmatize, when we have conversations like, yeah, cancer, it's just cancer, what's the big deal? The other person is like, oh yeah, it's actually what's the big deal? So when somebody like Radhika, who has recovered, who's on the other side, goes up to them, and I've seen some conversations while I was there and she happened to come in, and they're like, but did you also lose hair? But you to look normal. You're looking fine. I remember one of our I took her and I said, I want you to meet this person before their surgery. And the first thing she said to Radhika was, but you look normal. And then Radhika was like, of course, what did you expect? And it was a very sweet interplay because that eased a lot of the anxiety. So we did nothing. Radhika was just kind enough to, be with her without any, thing attached to it. And the person just had to see that I'm not just saying something just like that, but I actually have a fact to prove it. So I think sometimes I just go with their pace rather than pushing them.
So when we began this support group, why did it start? Was because when I was in treatment in the daycare, I just go and okay, so I didn't have any hair, but sometimes I had a scarf. Sometimes I didn't even have that. But I had my earrings and I was dressed all right. And, I was talking to somebody, laughing with somebody. And this lady came up to me and she said, do you have cancer? I said, yes. Are you undergoing treatment? I said, yes, but you don't look like a cancer patient. And I thought, why? Why do we have these stereotypes that a cancer patient has to look a certain way, a cancer patient has to behave a certain way? This should not be there. We need to normalize this disease. You don't go around saying to people who've got diabetes, you don't look diabetic. You never say something like that. So why do you say something like you don't look like a cancer patient? But again, as both of you have been saying, the only way we can normalize this disease is by talking about it, by spreading awareness about it, by letting people know that, it's no different from a cardiac arrest or from, anything else.
I think it's fear. Is it important to share all information with patients and help them process the information and family around them to help them process the information? Or do you think it's okay for some families to hide information from parents, especially if they are elderly, and from patients themselves?
We have to take each individual differently, and the doctors and Hiba and others have to assess, what they are capable of processing. As far as the family is concerned, hiding diagnosis from parents, etc., as long as the parents are not the patient themselves, is for the family to judge whether it's going to have a negative effect on their health and how they're going to be able to take it, and we need to protect them like I did in my case. But I honestly feel that the important information should not be hid from the patient, because A, we need patients' cooperation in the treatment, and B, especially things like if they don't have long, I think they should be told, because otherwise we are depriving them of a chance to do a few things that they may do, that they may want to. But then again, you have to assess the individual. Some people may take it in just the opposite way.
Hiba, what's your take on this?
I think that why, especially like I said before, that it's also a very society, community specific thing. That when we protect someone, that's one of our very basic instinct to protect the other person, that they won't be able to handle it because they're ill, but I can, right? So let me be the sponge for the person, my family member, my friend, whoever, whatever relationship I share with them. And so we deprive them of knowing what their bodies is doing or undergoing. We take control from them. In our most positive, loving intentions, we're not giving them the agency, and we took it away because I made the decision for somebody else. However, like Radhika said, and for someone herself who's been through that, there is a certain level of sensitivity that is required, because that's how the community works, right? That's how our Indian society functions. We can't surpass that. There are people coming back saying, you know what, I need to know step by step what is going to happen. That's my control. We respect that. Sometimes when the first question is, how long do I have to live? Day one, give me the prognosis. Some of the doctors end up doing that, but then it's too hard and difficult information that we didn't even understand how hard it will be. So in moments like that, we play it by the ear, where we look at it from a perspective that we see a sudden deterioration. The person is not able to make sense of what's happening to their body, but at the end of the day, no, something's not right with my body. How much are you going to delay? I never like giving positive hope or false hope, and thankfully as a team, none of us do. But what is the alternative to that? Sometimes the family's anxieties is seen through. I mean, these are your loved ones. You've grown up with them. You've lived with them. You know when their face changes. You know when the doctor comes in and doesn't have a very happy face. You know it. You're seeing your doctors day in and day out, right? It's a relationship that you build. We all carry each and every patient of ours, whether you're with us for a short period of time, whether you've finished the treatment, you're living touchwood healthy lives, all of that, you stay with us. So it's important to know that what will work for them, like she said, that you assess the situation. Is the emotional fragility causing, say, for example, panic attacks right before the surgery? So do we want to overindulge? First, you'll have surgery, then you'll have chemotherapy. Let's just let the surgery happen. Then we'll talk about the chemo. Then we'll talk about the radiation. So I try to divide it accordingly. We discuss it. Here we have a system that we have all the treating people, the entire team, that, okay, you know what, this person will need this kind of help. We'll introduce. So we look at it in a phasic manner. So what we do is I try to keep the feedback with the treating doctor very regular. That, you know what, they're doing well. I think they're emotionally a lot more, say, coping very well. They're a lot more resilient. So I think we can broach a particular topic or B particular topic. So let's just talk about the surgical implications, post-op or pre-op, and then talk about chemo if and when they need it post-biopsy. Why do we have to overindulge? So that's something we can tweak in. But to over-bombard, and we call it the disclosure and non-disclosure, right? So when research is being done on those things, they talk about that I mean, there are multiple researchers, so I won't get into that, but that's also about how much to disclose and who decides for the patient, who takes the call. I take the call, but with what agency? So as an oncologist, what agency do I have? Just because I'm their treating physician doesn't mean I take all decisions for them. So,
another perspective is at the time when the prognosis was bad for my brother, did not want to immediately tell my parents because I was scared of how they would react. But I was convinced by my husband, no, you need to, because the shock is coming anyway. You will not be able to prevent it. So it's best that you level with them and you share as much information as possible. So literally, I had the internet open and I showed them the anatomy and I described everything that was happening. So they knew, and I think information does that a little bit. I don't know whether it takes the fear away completely, but it makes you feel a little better. Radhika, what's been your experience?
Yeah, that's how I started, by telling you that my fear diminished with the knowledge that I learned, with all the reading that I did, by talking to the doctors, etc. It doesn't go away completely. That I don't think is possible, especially for the patient. And I think even for the carer. It doesn't go, but it does diminish when you know something. A large part of the fear is the fear of the unknown. And then when you know things, it does automatically begin to lessen.
Just coming back to mental strength, when you were diagnosed with it, somehow you say you mustered up that strength, right? How did you process it? We were talking the other day to Rajneesh Singh, who's been diagnosed with stage 4 colon cancer. And his way was writing, and that helped him. And to each their own. What was your way?
It was just rationalizing in my mind that, look, this is my diagnosis. This is what I've learned about it. And lucky for me, as you said in the beginning, I was stage 1. So I just tried to get information for my particular diagnosis. I didn't try to get too much information because that would have been too confusing. So I talked to my doctors about my particular situation and my diagnosis and learned about it. And I knew that, the statistics were good, the prognosis was good. So that way I was not in too bad a place. It was just a question of having to get through the treatment. Now that is, everybody has their own ideas about chemotherapy. Am I going to be able to make it? It's made out into a huge monster, this chemo thing, again, because we have never actually sat down and seen what chemotherapy is. That is where, again, a support group comes in, because there you have members who've actually been through it. And you're able to talk to people who have had the chemo drugs similar to what you're having, and they are there in front of you, and they're able to tell you, look, if this happens, do this, if this happens, this, and before you know it, the treatment will be over. And yes, that is how it is. And talking to people who have got a first-hand knowledge of the journey is very important, and it can be very therapeutic. It can be very calming. With all respect to the doctors, their knowledge of the disease is at best secondhand. What they've seen other people go through, what they've heard from their patients, etc. But here are people who have actually experienced the thing. So there's a difference between sympathy and empathy, and this is where others will tell you that, oh, you're going to lose your hair, don't worry, it'll grow back. But here are people who've actually lost their hair. They know exactly what you're feeling because they felt it themselves. And even now, when we go to a support team to meet people, we tell them, sometimes I catch myself saying, oh, don't worry, you will come out of this fine. Then I have to stop and say, look, I'm talking 9 years retrospect. I need to remember how I felt at her particular stage. And then what you say is very different. And that is where they connect. And I can see people smiling and their anxiety lessening after they have spoken to us. We come from a very different space from where the professionals come. And I always tell them that, look, a support group is not a substitute for anything professional, whether medical or a mental health. For that, the professionals are there. And when you need them, you go and see them. Do not substitute what we say for professional information.
No, but, it is what its name is. It's a support group. And
exactly.
That's what it is. And it's got people who have been through it and can tell you firsthand. And it's amazing that you've created something that you yourself felt you lacked when you were.
Yes. Yes.
So that's incredible, both of you. Hiba, let me ask you, do you feel that there are higher chances of patients diagnosed slipping into depression without even realizing it? So what are some of the signs that they should watch, or maybe caregivers should watch out for?
Yes, so I won't just say depression. I'll say many other aspects. Sometimes people have a lot of, distress at an overall level. Sometimes they're very, very anxious. And I know these are common words, anxiety, depression usually, but there are other aspects which may not have direct implications to them, but, carers, for example, their relationships, their functionality turning into a dysfunctional space. So their work, their education space, or their personal space, their social circle. Sometimes what happens is that people become very, we call it hypersensitivity. So they're emotionally a lot more volatile than what the other people would be around them. Now, for them, they say, oh, you're misunderstanding me, you're not understanding me. And they're right, you're not understanding them. You can't just say it'll be fine. They'll be like, you're not going through that, right? But it's important to know how their frustration tolerance, we call that, right? Are the triggers very quick? Are the triggers a lot more than what they used to be? We look at aggressiveness, we look at irritability, we look at restlessness in general, to do things, right? Being very snappy. These are common symptoms that we find in a lot of people. Crying spells, sleeplessness, loss of appetite, right? So now that is also a side effect of chemotherapy. But sometimes people in their anxiety and depressiveness also feel like not eating. Now that's impacting their body. So it becomes a three-way process. So what part of it do we see? Because a lot of times doctors call me and they say, look, I understand there's pain, but this person or this patient who's admitted, I feel like is not eating, not because of our pain, but I think they're emotionally uncomfortable. Can you please assess? So then, we try to assess and understand that, okay, is the pain, somatic, which is physical, or is it psychosomatic, which is more stress-induced or physically, distressed? So sometimes they're angry. Their bodies get very, very fatigued. Now, fatigue is also what cancer-related treatments can do. So then it worsens. So these are sometimes some of the signs that we can look at. Are you emotionally volatile? Is the, reactivity emotionally or sensitivity based, very high? For me, the comparison point becomes the day I meet them the first time. I understand the families are like, oh, but they weren't like that. They used to be jovial, or the patient themselves tell me, I used to be a happy person. Why am I like this? And I said, you're not like this. Anybody, you're not in an amusement park. Nobody comes to the hospital happy, right? So obviously you're not here by choice. So it's okay if you're uncomfortable and you're not being your jovial self. You will towards the evening when you get out of the hospital. So nobody's expecting you to do that, but their need to tell me is not to tell me. It's them hearing themselves and reminding that this is not my core personality. Because they're also missing that, right? They're also seeing a different side to them. The families or the carers are like, they weren't like this. They were they were the life of the party. When they say that in front of the patient, there's again further stigma and loss that I'm not the life of the party anymore. I'm this annoyed, irritable, grumpy person that people see me and are afraid to talk to me. So we need to also see the situation is different. So instead of judging your own self, we look at it from a perspective of, okay, we can't be in the zone of toxic positivity that everyone has to wake up sending positive wishes. You have to start the day with sunshine. I remember very early when I joined this organization, and I said, such a beautiful weather outside. And it was my little attempt to just say hi to them, break some icebreaker. And I said, beautiful weather. They were having a bad day because they were pricked 3 times and the cannula didn't go in. So they were in a lot of pain. And they said, what weather? It's behind me. And I immediately realized that they're not having a good morning. But the weather was the most beautiful weather that, one of those few spring days where you have nice breeze. And I said, oh gosh, why did I do that? From there on, I started giving them an example, how perspective shift. So I said, somebody who's recently got into a relationship loves the weather because all romantic songs fit the right chord. But somebody who's just had a breakup or a bad day is listening to only sad songs, and this weather is the most gloomy thing that they can happen. So it's the change of perspective, how we're looking at the same window. And that's what, when Radhika said that they relate to her differently, I agree. So when I meet them and they said that, what would anybody else understand with hair fall, right? I said, you're absolutely fair to say that. And I will never be able to say what cannula feels like, but I relate to the pain of it. Because when I have a headache or when I have a toothache, even a nail ache, it's really bad. So I can't imagine what pain for you feels like.
Now, I want to ask you a question related to unresolved emotions that you brought up, and I hope I can articulate it well. Usually, as a culture, a majority of us don't confront emotions, don't like to talk about our emotions, men and women. Perhaps women do it a little bit more, but at least in our family, we didn't. And when something like this happens, when you're confronted with cancer, it all comes out, right? Suddenly, you have to confront that, which is why, someone like you is important. This is in no way to push anyone towards therapy or counseling, but this is just to bring out a perspective that while you're getting your treatment done, this may be one of the aspects that could help in balancing somewhat your emotions.
The thing is, Shruti, that all said and done, there are financial implications to it, right? It comes with a cost many times. And I won't get into it because I know that's an entirely different arena. So people then pick and choose that, is this important physically for my body? Is it a situation, will it give me a safe and an improved life or not? And that's how they evaluate, not realizing that this is as important a necessity as my physical health. So it's not about this or that. We try to portray all of us together as a holistic group, that we're looking at you both emotionally, physically, as well as at a caregiver or a carer perspective. So it's a more triadic conversation that we're having with you. You're not just a patient for us who comes and goes. We equally respect each other as a team, or also that, yes, mental health or emotional health is equally important. I wouldn't be here if that wasn't the case. I have seen and been in places where this was not even given, right? So that this is important. Your subject is important, and the patients realize that. Like you rightly said, that it's not about this or that. It's about that this goes at a parallel level. And not because you have to be shocked or you have to be in denial on day one. You might be the most accepted person. Sometimes people come to me 2 years after their treatment completion. And they're like, but I was absolutely fine. What's happening? And that's the confusion is at another level. They're like, what's wrong with me now? And I said, you're having long-term effects. You're having long-term depressiveness or anxiety coming in, or the fear of recurrence, and again many other things.
Well, sometime or the other you have to confront it, whether you do it today, whether you do it a couple of months later, a couple of years later, some way or the other you need to. Radhika, let me come to you. Men and women, and especially in our culture, women, even if they are patients, most of the time they also convert themselves into caregivers as well, like you did. What is the challenge in that? How important is it for them to take care of themselves first?
Absolutely. If you don't take care of yourself first, you're not going to be able to take care of anyone else. So it is very, very important to take care of yourself. And that is where I face the maximum difficulty, because, after treatment, the treatment does have its side effects, and you do feel tired, and you do feel not hungry, as Hiba said, and you don't want to do things, to feel nausea. And there was nobody to see me through that. I had to see myself through, and there were times when I was neglecting it. And then when I was neglecting it, I did not have the strength to go and help anyone else. And that's when I had to take a toll of what I was doing to myself. So I started, just spending a little more time with myself. Whatever I could spare from the hospitals, whatever I could spare, I would say, okay, now this is me time. I need to give myself me time. I need to look at what I have to eat. I need to rest. I need to be able to walk around a bit, do a bit of exercise, talk to other people, indulge in something different, something like music, or read a book or whatever. So unless you do that, unless a caregiver has some time to himself or to herself, they're not going to be able to look after the person who needs the care.
Hiba, I want to talk about caregivers here. Why is it important for primary caregivers to also ensure that they're taking care of their physical, emotional, and mental health?
It's so important, Shruti, because they feel that they're made of steel and nothing can cross them. And what happens there is that they don't realize the emotions engulfing them, because that doesn't seem like the need of the hour. It's also difficult for them to answer questions beyond the patient-related questions. And sometimes when I would turn to the caregivers and say, how are you? They'll start telling me about the patient. That's the default that's set. There's immense amount of caregiver burnout that I see on almost a daily basis. The burnout is also about what's going to happen. So all the things we've just talked about, from a patient's perspective, exactly same thoughts are replicated by the caregivers, but they're the lesser known heroes. So they're actually the most underrated. And they said, you know what, I'll pull through because my body is not going through the intensity that their body is going through, but they're managing work of the patient, work of the home. The responsibilities that the patient had now are suddenly onto you, especially parents of small children as well. And so you don't know how exactly that plays in the long run for you and on your own mental health. I often say one person gets diagnosed, the entire family gets diagnosed, because that's how closely intertwined you are. So that's why it's so important to look at caregiver burden and fatigue, which sometimes, because of the rapport, because of the comfort, I sometimes take the caregivers, out of the room, maybe in a more private space, ask them to visit in the OPD when the patient is, less in need of them or their presence rather, and have a conversation. How are you doing? And sometimes it's so difficult, and I can't do that. I alone can't do that to the hundreds of people who are there. Sometimes carers are in that very toxic positive space. No, nothing's going to happen. Nothing's going to happen. Not realizing that there is evident deterioration, but they're so afraid to confront it, that what's going to happen to me beyond the patient, that it's such a scary thought that let me not address it at all.
Caregiver burnout, can you give us 3 signs to watch out for?
A lot of times they end up having a lot of crying spells. Sometimes they're making a lot more mistakes at work or at home. They're snapping. Their reactivity becomes many times aggression and anger. So as a result of that, they end up feeling they're fighting against their own emotions. So what happens is that when that fight ends up becoming, higher and higher and more intense, I'm fighting against myself. That will lead to a breakdown. So I may have sleep disturbances, I may have loss of appetite, panic attacks, which they can't identify, because their idea of panic attacks would just be breathlessness. There are many other symptoms attached to it. So they're having active panic attacks multiple times a day, which they don't realize are actually a result of their severe psychological distress.
And even for caregivers, it could impact their long-term health if they don't watch it right now, because it may show up as an emotional need right now, but it will take its toll eventually. Radhika, how have you ensured that everybody around you maintained that level of not just positivity, but strength?
As I said, I didn't have too many people around me. There was nobody. It was just my husband. And he was actually going through a very difficult time himself. But again, to keep him going, I had to keep myself going. Mm-hmm. And so the only way to ensure the other people remain positive was to stay positive myself. I did not have a choice. So I understand that my situation is a little different from what most people go through. Hopefully nobody else has to go through something like this. I used to come home to an empty house. Mm-hmm. I used to finish my treatment in the hospital and go to another hospital and spend the night there with my mother in one room and my husband in the other room.
That's a tough place to be, Radhika. I really admire you for having gotten through all of that. Do you think people are more receptive, Hiba, talking to a psychologist now, whether it's caregivers, whether it's patients, or do you still feel that reluctance?
They are far more comfortable. I've been here long enough as well. So obviously they associate a very default presence of a mental health professional. We do a lot of, mental health specific conversations and talks. All our oncologists talk about a psychological or a psychosocial aspect of the illness as well by default in all our conversations. So they see us synonymous with the treatment. But a lot of people actually end up looking for somebody working with specific, now it's the time of super specializations, right? So everyone starts looking at, oh, is there someone specifically dealing with this? There has been an immense rise post-pandemic, because now people can reach me, so they can be on the bed, in their rooms, on their tables or whatever, and talk to me rather than coming to the hospital, which makes them feel like a patient all over again. Sometimes they're afraid to come back because this place or any other hospital gives them bad memories. But the caregivers follow up and they said, please, can we meet virtually? So at least the distance isn't a problem, or the space isn't a problem. They create their own safe space. So yes, I've seen a rise, both oncology and non-oncology actually.
Radhika, let me bring up something very sensitive here. We were talking earlier and you mentioned physical and sexual challenges that are part of a cancer diagnosis, that many patients and even caregivers are reluctant to talk to a specialist about. Talk us a little bit through it.
So this happens more when you've had a mastectomy in the case of breast cancer, or ladies who've had surgery. For them, it is a huge issue to be able to maintain relations with their spouses and their partners. Sometimes it's just a question of body image, and they feel, and I think Hiba will be a better person to talk about that. There is so much reluctance in our society to talk about sexual relationships in general, nothing to do with cancer, just in general. People just don't talk about it. And I have seen women who have suffered because they don't know how to bring it up with their spouses or their partners. I have seen women whose husbands or partners have left them because they were not comfortable restarting a sexual relationship with them. So there are partners who walked out on the women. There are women who come to us and say, there's something I can't talk about to my doctor. I feel, because the doctor is a male doctor, and they say, there's something I can't talk to them about. And then I always refer them to Hiba. But before Hiba was there, I would try and refer them to a lady doctor on our team, but they didn't feel comfortable talking about it. And you cannot have an honest conversation on sexual and intimate relationships unless there's both the partners are there. A one-sided conversation is not really going to achieve very much. And very often it's the male partner who's so reluctant to talk about it. In fact, we used to have sessions on these as well for our patients. And at the end of one session, I got so much flack from one of the husbands who came and said, don't you feel embarrassed and ashamed that you're arranging sessions like this? This has to change as well. We have to start talking about difficult topics. And unless we do that, things are going to be very difficult. And more women are being diagnosed at a younger age. They're in the prime of their life. They're in their late 20s, 30s, 40s. And if they're going to face this kind of thing now at this stage in life, how are they ever going to, blossom and thrive and, resume a normal life after the end of their treatment?
Hiba, first of all, answer this one question. If you have undergone cancer treatment, if it is an early stage, and of course the prognosis being good, and you can have normal sexual relations going forward, somehow there's misinformation out there that something is wrong, so the other partner is reluctant. When a couple is going through this, what is your advice?
That's where the importance of sexual health communication research comes in place, which we don't have any at the moment. Through my research, which coincidentally happens to be that as well, when we see the psychosexual implications of cancer in Indian communities or Indian patients or Indian healthcare systems, we don't check in on that on regular checkups as follow-ups of cancer and related treatment, or even in the period of survivorship. It's not considered to be important enough, even by healthcare professionals or oncology professionals. I think the whole concept around sexuality also sticks to the point of fertility, infertility, dysfunction in terms of, erectile dysfunction, reproduction, and intercourse, whether you're functional with it or not functional. Nobody talks about intimacy. Nobody talks about desirability and arousal. And yes, these are sensitive conversations, which people find it difficult because a lot of it gets impacted post your treatment or during your treatment, which causes friction, which causes discomfort while you're engaging in any kind of sexual or physical intimacy with your partners, specifically cancers like the head and neck, gynae, GI, even breast for that matter. We only talk about it theoretically, which is another interesting observation research-wise, that people only talk about breast cancer with sexuality. Why? Because breast is, a lot of feminist theories and a lot of theories suggest that breast is looked at the object of gratification. Now, who decides that? What happens internally? So when a woman is said that your womanhood is gone, what does she think about her existence? And a lot of the identity shift happens there. Yes, people can have normalcy. People do have normal sexual relationships, or, they proceed with the treatment. They're just told not to, plan or have pregnancies during the chemotherapy, because obviously it's the body's having a lot of chemicals and things like that. And people do talk about the fertility bit, but nobody talks about resuming sexual intercourse or activity. Many times there's also age-related stigma. I've had people in their mid-60s, early 60s say something like, during one of our sessions, once they were comfortable, what I'm about to ask you, you must be thinking, this old lady is asking me such a question while she's on her chemo. Now look at her. She's supposed to think about her treatment, and she's talking about sex, but she's supposed to talk about, her treatment and her body. It was a huge projection of what she may have heard or she herself thought. I didn't think of it like that. I didn't judge her. I said, that's absolutely fine. And there's also this age differentiation. Somebody in their 70s talking to me also feel like I'm talking to a young child. And that's something I hear a lot, which again, I think I've embraced. That's virtue of my profession. But yes, people in their early, in the period where some of them choose to be, say, and it's not just about marriage, people who are sexually active, having their live-in partners or with partners, they start having difficulty because they're like, what else is holding us? What is binding us is now that one thing is gone. So we're not even talking about it. Sometimes the women in particular, a lot of research suggests, a huge percentage of women take it upon their own responsibility that I'm not able to satisfy my partners, my male counterparts, in a very heterosexual relationship I'm talking about, that my male counterparts are not being satisfied. So there's so much guilt. But talking about their needs, their desires, when there's a male patient, fewer women complain. But men, many times, gender differences also suggest they let go of the women, because then our families ask them to leave, because the one thing they're supposed to do is to, say, produce a child or, satisfy their sons or whatever, is they're not doing. And now they're quote unquote not even women enough, or they're defective. And I'm talking about it's irrespective of education or not. So a lot of, and obviously that's an entire plethora, when we talk about sexual health
discussion on its own. I'm so glad it's come up in today's discussion, because these are important discussions to have.
Yes,
and
absolutely. But as you said, Shruti, there's also a lot of misinformation out there, which people just imbibe, and they don't bother to, check it out either with their doctors or anyone, like having sex can lead to a recurrence of the cancer. That is one thing that is going around. And so many people actually believe that, but they won't talk about it.
And also that the patient is so fragile that we'll hurt her. So a lot of people don't want to engage, or show any kind of intimacy, not realizing that intimacy can also have levels, right? It's not just sexual intercourse or, sexual intimacy. It could just be hugging the person, holding hands. Or they feel so fragile that, they're dealing with like a glass object, right? That will break, which is frustrating for both of them, because nobody says it, but they're both feeling it and they're not talking about it. And it comes out as this outburst where we realize, oh, this was the crux or the root of the broader outburst that happened with them.
And once again, this is a topic that requires conversations. It also perhaps requires sometimes professional intervention, which couples don't seek. And so it gets worse. And then communication breakdowns happen. That's why. So yes, we are going to have another discussion on this. I'd really like to end this with, when the cancer is terminal, what are some steps that a family can take?
Well, one is acceptance. It doesn't come easily. It is accepting that my loved one is not going to make it. right? That is step one. Also, they can seek support. There is no harm. There are organizations that give end-of-life support. TAN support is one of them. Perhaps, they can enroll and register for these, where they send home a team to help not just the patient, make the patient comfortable, but also be with the family and give the family counseling on how to handle the last days. The other thing that families have to accept is that, it is better when the doctor has said that, look, we don't have much time, to take the patient home and not leave him or her in the hospital, in the ICU, because in the ICU, you're surrounded by wires, by machines, and the caregiver can just the family can just meet the patient for a few minutes, twice a day or 3 times a day. But at home, some people are afraid. There are different reasons why people don't take the patient home. But if it is at all possible, with the help and support of organizations, it would be best if the patient could be taken home.
Again, it depends from family to family. And I think very many families opt to have their loved ones in the ICU for various reasons. And, we don't judge. Hiba, what is your advice to families when they are dealing with this level of grief?
Yeah, I was actually just coming to the concept of grief and how they're anticipating something that's been told to them. They channelize all their energies into protecting the patient, not realizing that they're also experiencing loss as they're proceeding. It's important to address what that absence looks like, because that's what is the biggest fear in that moment. Sometimes people want, they decide they're going to leave the patient comfortable, but suddenly the fear is so much that they said, no, let's just try one more time. Let's just do one more thing at the cost of the suffering of the patient, right? Even if it's not advisable. And it's important to look at what my emotions are doing, what kind of impact it's having on my life. How do I see the loss or the absence of that person in the relationship that I have? Because I'm the one who's going to be left behind. So sometimes we become selfish because I want you to live for me, despite knowing that the patient is suffering really badly. And so I don't have an advice, but I feel like at that point of time, knowing what your safe support systems are. It doesn't even have to be a mental health professional if in that moment you want someone who just gets you and your family, but reach out. Don't isolate by thinking no one can understand my pain. Yes, your pain in that moment is the biggest pain that you're going through, and no other pain looks big. But you might have people who relate to the feelings of loss. May not be in the same way, but they can hear you. They can understand you. Tell people what you need. Tell them, I don't want random advice from you. Just listen. Just let me vent. Yeah. Whatever emotion you're going through, there's no right and wrong emotion. So don't judge yourself if you're having an anger response or you're having a sad response. People tell you, stay strong, don't cry, don't cry. I wonder how crying is associated with staying strong. That's important to be told. Any emotion is right. You do you decide what you want to do. So yeah, I guess that's something that I've tried to start embracing this. I didn't either for the longest part of my life. So I think I'm now talking that I'm practicing what I'm preaching. Earlier, I think I was a bit on the hypocritical side where I would tell them but not practice. And I realized, oops, not working.
Same. I'm on the same boat because everything that I said to others, I was unable to follow when my time came, And the other thing I think through experience I've learned is that everyone reacts to grief differently, and you've got to give that space to everyone to feel the way they do. For instance, my father felt a lot of anger. My mother, on the other hand, cried the entire time. Kids have their own responses. Sometimes it's difficult to tell with kids. So to each their own. But any last thoughts from the both of you going forward? If there is a patient that needs to hear this, what would you tell them?
That there is help available, and do not hesitate to reach out. People are very hesitant to reach out. They feel that they can cope everything by themselves. They don't need help. You don't know how much you can be helped. The journey of cancer should not be undertaken alone.
Hiba?
I think for me, I think I'll just add, just add to what Radhika was saying, that you don't have to create a system where you're alone, right? I understand the experiences your body is going through that on your own, but you can choose to pick people who can be with you and walk that step with you. Secondly, that, emotions are actually what makes us. And like I said before, on a slightly lighter note, if your headquarters are not working, your entire hardware system will collapse. So, just like any, system, any country where the headquarters are not okay, the country will collapse, and that's what it is. So I'll be a bit, sounding pompous right now, but I have this running joke with all our oncologists that, pick and choose for both yourself as well as your patients. And I practice what I preach. I feel like it's important for me to realize what vulnerability looks like, to take therapy, to take supervisions and things like that, to know that you're also checked, you're a human. And that's what the person feels on that side of the table. So don't hesitate. You might just find something really beautiful and interesting in terms of self-reflection. And I call it the mental gym. And I think everyone should invest in it.
It's a wonderful way to end. Take care of the headquarters. And number two, what Radhika said, don't be afraid, don't be hesitant to reach out, because you'll be surprised how many people do actually care, and they can be a wonderful support. And they don't necessarily have to be medical professionals only, but they're friends. There are support groups like the one Radhika runs. So reach out. And on that note, thank you, ladies, for joining me for this really wonderful, very insightful discussion. And I hope to have more of these in future. Thank you.
Thank you.
Thank you so much,
you
Shruti. It was a pleasure.